Welcome to AETCM, the Emergency Medicine channel. Shall I?
Yes.
Today I'll be presenting a case of 41-year-old female who presented to our ER with complaints of excessive thirst, increased urine output since last 3 months, and multiple episodes of vomiting associated with generalized tiredness since last 2 days. On 10-second assessment, patient was conscious oriented. On airway was patent. There was no secretion, gurgling or pulling of saliva. On breathing, patient had a respiratory rate of 16 per minute with a saturation of 98% at room air. On circulation, patient had a BP of 110/70 with a pulse rate of 92 per minute. On disability, patient's GCS was 15 out of 50. Pupils were equal and reactive to light. On exposure, patient was febrile and GRBS was 162 mg per deciliter. At this point of time, we had taken a VBG since patient was complaining of multiple episodes of vomiting. VBG was showing a pH of 7.4 with a bicarbonate of 25. And the electrolytes were sodium was showing 162 with a potassium of 3.6 and calcium of 1.12. Creatinine levels were 1.18. Coming to the sample history.
Have you taken urea? No. This VBG.
Coming to the sample history, 41-year-old female who's recently diagnosed with central diabetes insipidus presented to our ER with complaints of excessive thirst, increased urine output, nocturnal water craving since last 3 months. Patient complains of multiple episodes of vomiting and generalized tiredness since 2 days.
Normally, what are the reasons for polydipsia? Polydipsia is more water intake.
It can be due to diabetes mellitus. Most common diabetes mellitus can be
Most
there.
common thing is what?
Dehydration.
Thirst.
Dehydration. Then diabetes mellitus can be there. Then HHS patients also can develop polydipsia. Then in ICU patients, if we look, elderly patients can develop, psychiatric patients can develop.
Psychogenic polydipsia
can be there. In small infants, it can develop.
Okay.
Now,
then diabetes, like you
diabetes
insipidus.
Patient had multiple episodes of vomiting and vomitus was food particles and fluids. There was no history of any fever, abdominal pain or constipation.
But if you are treating a psychogenic polydipsia, what will happen to the sodium level?
It will be normal.
It will be normal. That is the main thing. So when you compare psychogenic polydipsia and diabetes insipidus, these are the two important conditions. And sodium levels in the psychogenic polydipsia is always normal. That body will try to maintain because it's a physiological problem. Whereas in diabetes insipidus, type 2 diabetes, all these things, sodium levels will be high. Okay.
Coming to the allergic history, patient didn't have any allergic histories to the drug. Coming to the past medical history, patient had complaints of increased thirst, increased urine output, increased nocturnal water craving since last 3 months. Hence, she was evaluated at multiple hospitals. On evaluation, her patient's serum osmolality was seen as 332 with a urine osmolality of 243. And then her serum sodium levels were found to be high.
Osmolality is very high, urine osmolality is low. Okay. That indicates?
It indicates to some diabetes insipidus cause. Okay. And her at that time, her serum sodium was found to be 164. Okay. From that hospital, in order to rule out this diabetes insipidus,
what are the common condition in emergency room? You can get hypernatremia.
Patient coming with severe vomiting, diarrhea.
Severe vomiting, diarrhea, sodium will be lost along with water. Hypernatremia.
If there is more, it can be renal or non-renal causes. It can be due to it can be hypervolemic hypernatremia. So in that, most common cause of renal can be when the patient is taking diuretics. If the patient is having some renal pathology, renal tubular acidosis, then it can be euvolemic hypernatremia such as diabetes insipidus. Then it can be due to hypovolemic hypernatremia.
So indirectly, hypernatremia tells you that patient is having dehydration. What are other parameters will tell you that patient is dehydrated?
Urea, creatinine
high
ratio.
Urea. Okay.
High urea, creatinine ratio can be done.
Okay.
From the outside hospital, MRI brain of the patient was taken, and in the MRI it showed pituitary glands were normal, no focal lesion was there, but posterior pituitary was not visualized. T1 hyperintensity was absent, which was indicative of central
Why we are taking MRI in a case of diabetes insipidus? What is the need?
Diabetes insipidus mainly due to two causes. It can be central diabetes insipidus or nephrogenic diabetes insipidus. So, in order to differentiate, we can have an MRI.
What do you expect in that MRI? What all things you want to see?
In central diabetes insipidus, bright spot will be absent.
Okay.
If it is related to the hypothalamus or pituitary gland.
Okay. What else? What are the other reasons?
It can be congenital or acquired causes. Congenital causes mainly due to the structural malformations of the pituitary or the hypothalamus.
Okay.
Otherwise, it can be to the genetic mutations in the AVP gene coding proteins.
Okay.
Then acquired, it can be due to mainly any trauma, any pituitary surgeries done, any infections like
previous history of accidents, trauma.
Any infections like meningitis or encephalitis, any tumors like craniopharyngioma, all these are the causes.
So these same patients can have anosmia, visual disturbance, diabetes insipidus. Okay. Any infections? What are
meningitis, encephalitis can cause.
Any other cause of pituitary involvement in diabetes insipidus? Any other condition, non-infectious inflammatory condition?
Pituitary microadenomas.
Sarcoidosis.
Sarcoidosis.
Microadenoma comes under tumor. Sarcoidosis is one condition which can affect pituitary hypothalamus axis and can affect all these hormonal problems. Okay.
From outside, they had also sent plasma ADH levels of the patient.
And calcium has got something to do, or should we evaluate calcium in this patient?
Yes, hypocalcemia can also cause increased.
Hypocalcemia?
Hypocalcemia is one of the cause of increased thirst in this patient.
Hypercalcemia. Hypercalcemia is one condition can produce increased urination, that can produce thirst, that can itself can produce renal failure also. Okay. What will happen in sarcoidosis for calcium? It increases. Okay, there also it increases. Tuberculosis also it can increase. And hypercalcemia due to any cause can produce increased urination, polydipsia, all these things. So calcium along with your sodium, calcium investigation also should be done.
In this patient, plasma ADH levels were sent and it came to be as lower than the normal limits. It was about 24. Normal limits, it's above 30.
Okay, so that tells you whether it is peripheral or central.
Central. There was a deficiency of antidiuretic hormone.
Okay, if it is peripheral, what will happen?
Antidiuretic hormone will be in normal levels, but its action on the renals will be low.
Okay.
And then the patient was started on desmopressin nasal spray.
That's okay. When the patient comes to emergency room, what is your role in this patient?
This patient came and we had done the sodium levels which was showing hypernatremia. So we immediately started on hydrating the patient well.
What is the type of fluid you want to select?
If the patient is in euvolemic hypernatremic state, then we can go ahead with D5 water or half NS. If the patient is in hypovolemic state, then we have to give normal saline.
Okay. Ideal fluid is always dextrose containing solution, or you can ask the patient to take more of water, oral fluid also. If half normal saline will be also beneficial. Normal saline is not a good choice. Even if the patient is having dehydration, you can correct it with D5. Okay. What is the problem if you correct with D5 to the patient? Can you correct dehydration with dextrose containing solution? Is it possible? Yes or no? Is it possible to correct dehydration with the dextrose? Initially, it will go to intravascular compartment. Within no time, it will shift to extravascular compartment. But the problem in diabetes insipidus, what is the BP in this patient?
BP 110.
BP is normal. So, intravascular volume loss is not there. Patient has developed more of extravascular volume loss. So, even if you give dextrose containing water, it will shift to extravascular compartment and it will get corrected. Okay. Intravascular volume deficiency you have to suspect only when there is a hypovolemia, hypotension, shock, all these things. It is not there. So, you can give dextrose also. Okay. For some time, it will remain in the intravascular compartment. Then later it will shift. Okay.
And then patient was started on desmopressin nasal sprays.
How do you calculate volume loss? I am not interested in desmopressin because you are in emergency medicine. You have to learn more about correction of the patient's initial problem. Desmopressin, once you start, patient may improve because it's a deficiency of ADH. Okay.
Patient's fluid deficit was calculated by Goth's serum sodium minus 140 divided by 140 into 0.6 into body weight.
Okay, so how much volume deficit will be there in this patient?
Usually it will be around more than 5 liters. In this patient we had got around 5 liters of fluid deficit was there.
Okay, can you depend on the urine output in this patient? Most of the other condition where you deal in emergency room, you can depend on the urine output and tell that patient does not require more volume. Can you depend on urine output in this? This is one condition where you cannot depend on the urine output to see whether the patient is dehydrated or not. Because patient will have good urine output in spite of severe dehydration. Okay, so you cannot depend on that. So what are the other things you can check for? Clinically, how do you know that patient is having dehydration?
You should check for the skin turgidity. Sunken eyes can be looked. Dry tongue can be looked.
Okay. IVC?
IVC also can be checked.
Okay.
So in this patient, there was a deficit of 5 liters of water.
How do you correct this water?
We corrected with a D5 water. So if the cases of chronic hypernatremia, then we have to correct it very slowly.
Okay.
So the correction should be around 0.5 milliequivalents per hour.
So when the serum sodium is very high, what will happen to the brain cells?
Brain cells, the water content goes outside of the brain cells and brain cells shrunken.
And it will become
shrunken.
Okay.
And then when we, if it is an acute lethal dose of sodium chloride has gone for the patient, then we should correct this hypernatremia very rapidly. Okay. Within 6 hours, we can correct the hypernatremia.
So if it is an acute problem, correct it acutely, rapidly. If it is a chronic problem, try to give some time. Otherwise, patient will develop something, edema and problems can.
Within 3 days, the brain cells will be in equilibrium. Okay. So if we, after 3 days, if we are correcting, then we have to correct it very slowly because again, from the extravascular, if the fluid goes into the cell, there will be cerebral edema. Okay. Hence, we correct it very slowly. Okay. So in this patient, since the condition was a chronic condition, we had corrected the fluid deficit very slowly. Okay. Over a period of 24 hours, we had corrected the fluid deficit. Okay.
What are the drug histories you want to take in this patient?
Usually, any intake of lithium can cause.
Lithium is
lithium used for mood stabilizer.
Mood stabilizer in psychiatric patients. Then
amphotericin B.
Amphotericin in ICU use lot of patients. Then other drugs. There are a lot of drugs which can produce central and peripheral diabetes insipidus. So whenever you see a diabetes insipidus, you have to always check the drug chart to see whether any patients are on any of these drugs. Okay, so that is very important. Should we do a Mandro test for this patient?
Yes, tuberculosis.
Okay, tuberculosis is one of the common conditions in our country which can affect pituitary hypothalamus axis. Okay.
Then patient's this fluid deficit was corrected, and then we were serially monitoring the sodium levels of patient. Also, we had given the subcutaneous desmopressin also. Okay. So serially the sodium was coming down.
What is the difference between IV desmopressin, subcutaneous desmopressin, nasal desmopressin? Is there any difference?
There is one thing is there is a dose difference between
dose all difference this. Is there. Rapid action is always the IV. And it is central diabetes insipidus always better to give IV desmopressin when he is in the hospital. Then later you can switch to subcutaneous or nasal
spray. This patient was maintained on the nasal spray from outside, and then on admission we have put into subcutaneous desmopressin. TID doses were put for the patient, and then the sodium levels were coming down for this patient.
Okay. So what happened finally? What are the other things you had to look in this patient? Anything else to be done?
We had also for initially for diagnosing that it is central, we had to make sure we had also done the water deprivation test for in this patient. Usually water deprivation test is done that we'll tell the patient to avoid the tea, coffee and smoking until 7:30 patient can drink the water. Normally it is done during the daytime, and from 8:30 onwards patient is kept deprived of water, and every 2 hours we'll be checking the urine osmolality, urine sodium, and then the body weight. When the body weight goes below 3%, then we stop the test.
Okay.
And then if the urine osmolality is low, serum osmolality is found to be high, then we can give a trial of desmopressin 2 micrograms of IM for the patient, and then again repeat the urine osmolality and serum osmolality.
Okay.
So if it shows an improvement, then it indicates of the central diabetes insipidus. So in this patient also we have done the same. And the initial values, urine osmolality was 297, which came to 421. And urine sodium also, initially it was 21, it came to 32 in this patient.
Okay. What are the treatment options for peripheral or nephrogenic diabetes insipidus?
Nephrogenic diabetes insipidus, one thing is that we have to restrict the salt intake and the protein intake. Then we have to give the patient good amount of hydration.
Okay.
Then we can also give the patient 3 drugs, that is the diuretics can be given. Hydrochlorothiazide diuretics can be given, along with we can give, if the patient is not improving, then we can go ahead with indomethacin 15 mg can be also given for the patient. Even if then the patient is not improving, in certain patients desmopressin also
Maybe
shows
effective.
benefit.
Okay, higher dose of desmopressin can be helpful even peripheral, but not a clear-cut drug indicated drug for nephrogenic diabetes insipidus. Okay, what happened to this patient afterwards?
The sodium is coming down. Serially, sodium monitoring is done. It is coming down.
Okay. Anything else you want to add? Okay. Thank you.